thank you again for a nice introduction. Okay, so yesterday they talked about the lack of support for women's health. Whether that's true or not, if we go to the ancient Greek history, there is the goddess of women's health, and her name is Hygeia, and in some books it's written Hygiena. And that's, we know the hygiene is just the goddess of cleaning and everything. So it is there. So the ancient Greek did care about women's health. And if you see that, this is Hygeia. And this is probably her father, the god of medicine, Arsiculus. And she's giving him a snake. And this is the snake, whether they refer that to, I'm sorry about that, the woman as a snake, but no, the snake is the healing. And this came, the healing came from the old epic of Gilgamesh. I'm sure here everybody knows who's Gilgamesh, that's the old epic from the Akkadian literature, that he was looking for eternity and immortality. And his grandfather, which is named Ortanabishtim, told him that to go too deep to the sea and find the plant of life. And he got the plant of life. Once he reached the earth, a snake came and ate that. So that snake refers for eternity and immortality. I think that's the. So this is the true symbol of medicine. This is the true symbol of medicine. Oh, I'm sorry. Okay, this is the true symbol of medicine. It's just the rod of Arsiculus together with the snake. This is the true symbol of medicine. Now, whatever this two snakes and some wings around that has nothing to do with medicine. This is called caduceus, and that's referred to the equality and true argument and justice. So I think this is the symbol of Mayo Clinic few years ago, and they committed big mistake when they used that symbol, but they corrected that. Now back to the difference between men and women. This is the difference between the room of man and the room of woman, and the car of man and the car of women. And this is the difference on the social media. Really, look at that, how many. And this is the difference. Whenever the woman looks at the mirror, she thinks she's fat. And the man looks at the mirror and she thinks he's thin. And the difference when we talk to each other, we say, hello, guys, that's it. And when they talk to each other, that's different thing. Okay. And this is really, George Carlin, he said, the difference between men and women, that the men are crazy, and the women are crazy because the men are stupid. So that's the only definition that we have. So let's go to the objective of our talk. Our talk will review the impact of gender and on the epidemiology of mitral stenosis and aortic stenosis. We summarize the challenges in the diagnosis of those disease and examine the comparative outcome between men and women undergoing valve surgery and transcatheter intervention. This is the main topic of the talk. If I have a time, I added an extra topic about evaluation, the valvular disease in pregnancy, but this is not important. I'll try to respect the time. So now for the incidence for valvular heart disease looks equal between men and women, around 2.5%. However, if we correct for the other things, and especially for the age, we see that the valvular disease is a little bit more common in men. So let's concentrate on the mitral regurgitation. So this is the study from the Mayo Clinic from Olmsted County, and they compared the result of the mitral valve surgery, and according to that registry, that for all the cases that was done between 1990 and 2000, that really the women are less likely to get mitral valve replacement. And the women really more likely to get intervened at a later stage when they are presenting with heart failure. 58 of the patients presenting with heart failure, that's for the female. It's less than 48 for the men. And although there was no difference in baseline of pulmonary hypertension or atrial fibrillation. And the early surgery, that's protective surgery when the patient has severe valve disease or severe MR and asymptomatic, happen in less than around 26% for the women compared to almost 40% for the men. So there is difference for the approach. Now we'll try to find what's the cause for that. We know that the advanced mitral valve disease cause ventricular enlargement, but the woman has a small body size. So if we now put the ratio between the the ventricle diameter and the ventricle volume and get the ratio to the body surface area, we'll get a larger numbers. And so we need to take that into consideration, not just to concentrate on the ventricular size or the ventricular volume. We need to get the ratio to the body surface area. So with that, we can intervene a little bit earlier for the woman because she has a smaller body size. And this study, probably you know, the idea came from Paul Grayborn, that when you intervene with mitral clip, on more disproportionate mitral regurgitation compared to the volume or the diameter of the ventricle, you'll get better effect. And that's what the real difference, why we got nice result from the COAPT study compared to the MITRA FR, which came from Europe or from England, did not show any benefit because they did intervene on a different ventricular size. Again, if we go to the result of the surgery, thank God, the mortality rate for men and women are the same. But however, after surgery, still women get more heart failure hospitalization. Again, probably from the same idea, we are intervening a little bit late and not taking into consideration this ratio between the ventricular volume and the body surface area. Even if for ischemic MR, we'll get different mortality results between men and women. Now, let's move from the mitral valve surgery and move to the mitral valve intervention with a replacement or a mitral valve tear. And there is no difference in this between men and women. That's a good point. And there is no increased mortality compared to men. However, the left ventricular remodeling after mitral valve intervention is better and quicker for women compared to men. So they will get regression of the left ventricular volume, improvement of the ejection fraction. So that's to keep in mind. Women remodel easily. It's not just due to their makeup. They remodel their ventricle easily after the valve surgery. So they do much better and get significant improvement. So this is the summary for the mitral regurgitation. Unfortunately, women do undergo mitral surgery less frequent and get less mitral valve repair. If we fail to index the echocardiogram left ventricular size and mitral regurgitation to the body surface area, we are underestimating the mitral regurgitation in the woman. Mitral valve intervention in the woman may be occurring at a late stage of the disease and contribute to a high rate of post-operative heart failure. So women experience worse clinical outcome after surgery, but the clinical outcome after mitral valve intervention are comparable, and women, again, more likely to experience reverse LV remodeling, and this has could be associated with improved cardiovascular outcome after transcatheter mitral valve intervention or replacement. Let's go to the aortic stenosis. So again, for the epidemiology, probably aortic stenosis occur more than in men compared to women. But now let's concentrate about the idea of aortic stenosis in a woman. Women may present later in their disease trajectory with some other risk profile. They have more concomitant mitral regurgitation, they have smaller LV cavity, and they have more LV hypertrophy, so they may present more with low flow, low gradient, severe aortic stenosis. And this is a diagnostic dilemma that's require us to do more tests, and probably the butamine echo or other tests for this. So that's to keep in our mind and put a plan. I'm not going to go through this plan, how to deal with low flow, low gradient, whether by echo or the butamine echo, and then put the plan. Now for the calcium score for the aortic valve, also the score for a woman totally different from the score for a man. So we say severe aortic calcification when the score is more than 2,000 Axton unit for a man. But for a woman, when it's more than 1,200, and you see that, compare that, this is the dotted line for a woman, for women, and this is for men. They have more, with the same number of calcification, they have more aortic stenosis, so their gradient is higher and the aortic valve area is lower. So that's to take into consideration, not to compare the calcium score and say it's the same as man. Now, what about the clinical outcome? Do the women do better with, say, SAVR, surgical aortic valve replacement, or with TAVR? And what are their clinical outcome? So let's compare after SAVR, after aortic valve surgery. And this is from the STS, the Society of Thoracic Surgery. And everybody take into consideration the STS score. From that study, that they noticed that women are more likely to have increased mortality and increased stroke and increased prolonged ventilation from that study. And from that, it came as a univariant risk score that a woman, being a woman, is a risk factor for a bad outcome for aortic valve replacement. It's known from this, so they kept everybody with that. Now let's talk about the valve with transcatheter aortic valve replacement. Now, for the women, because they have a smaller artery, it's difficult to go most of the cases through the femoral artery. So with that, either we get more access by transapical or transcarotid or through the subclavian, or the other thing that we get more vascular complication because of the small artery. And this is, you see that women are more prone to develop bleeding, vascular complication early after TAVR. So the outcome after TAVR is probably a little bit not as good for men just in the first 30 days. Now, on the long term, we'll see the really totally different thing. We get improved survival for the women compared to men. No difference in stroke or myocardial infarction. Although you see this difference, but it did not reach it wasn't statistically significant for the stroke. So this is, we know that now after, on the long term, women do better for TAVR compared to men. So, and that's happened in multiple studies and multiple meta-analysis that women are doing much better on the long term was TAVR. Now, why the long term is happening? We are having bad outcome early after 30 days, and this is improving much on the late. So if you go and I'm not going to go through this table, but we found from the meta-analysis that women going for TAVR are less likely to have comorbidity, whether diabetes, COPD, or hypertension. So, and they are depending on the STS score, and this high STS score coming, they're telling us that the woman, being a woman, from the STS score that we started with the surgical study, that is a high risk. But this is totally different. So women is not a high risk, but with that, we are getting this idea. So this is the explanation why we got that. Another explanation. This is the degree of calcification for a woman, and this is for a man. So we get less calcification. So the more calcification, there is more nodules that affect the valve implantation and cause really paravalvular leak. And paravalvular leak so happen more in men, and that's predictor of mortality. So paravalvular leak is predictor for mortality. This is number one, more calcification. And the other one is the annular size. The woman is smaller than a man. So the annular size is smaller. So with the large annular size, we may get paravalvular leak again, especially we exceed the upper size that of the valve which are available in our lab. So paravalvular leak is predictor of mortality in men. However, is not predictor of mortality in women. That's it. So we can accept the degree of paravalvular leak in women, but not in men. The LV regression, again, happen more quickly, and we'll get regression of the LVH more quickly, and because of the expression of the fibrosis is less happening in women compared to men. Look at this fibrosis in men compared to men. So we'll get less, quicker regression of LVH and less ventricular fibrosis after we change the valve. So this is one point. And this is all the studies for the partner for the valve replacement, comparing surgery with TAVR. This is for the high risk, the intermediate risk, and the low risk. And all of them showing that TAVR doing either the same as SAVR or probably better, especially in the low risk patient. And with that, the women doing much better. And the other point here, why is they are doing much better? Because of the theory of patient prosthetic mismatch. Okay, because with surgery, because there is sewing ring, so there is increased incidence of patient prosthetic mismatch, especially for the woman who has small body and small annulus. But for when you use TAVR, there is no sewing ring, so the incidence of prosthetic, patient prosthetic mismatch happen less frequently in women compared to a man. And that's as a predictor for mortality. And everybody remember the recent trial, the SMART trial reported by Roxana Mehran using this for patient prosthetic mismatch using self-expandable valve gave a significant improvement in the outcome. And there were 80% representation of women in that study, more than 80%. This is the first study that's showing significant representation of women. So this is for the idea of patient prosthetic mismatch. So to summarize, really, women are presenting later during the course of aortic stenosis and presenting with more LVH, advanced aortic stenosis, and low flow, low gradient. The perioperative mortality is higher in women compared to men for SAVR. However, the vascular bleeding for TAVR happen early in the first months, but on the long term, the TAVR are really giving better results for women. And they have, as we said, less LV fibrosis, and that may facilitate reverse remodeling and greater tolerance of paravalvular leak. Yesterday we discussed the idea, just remember, the hypertensive disorder of pregnancy is predictor for long-term increased coronary artery disease and heart failure, and in this study, increased incidence of mitral regurgitation and aortic stenosis. So this is the idea. I covered all the points. If you need me to cover the points of pregnancy, that's it. But I covered the thing that I want to do. That's unique consideration for this valve intervention. So.